the chance to share a little bit about the research that I'm doing. Okay, let me see. It looks like my screen sharing is paused. There we go. Okay, I think we're working now. 3 years into the pandemic and I'm still not very good at Zoom. So today I thought I would share with you just a little bit about my background and the trajectory that I had, give a broad overview of my research in quality of life and cancer, share specifically about the study of hope in advanced stage lung cancer, and then offer some reflections on the degree that I ended up pursuing and studying at Bethel College. Maybe I will minimize this so we can have that there. All right. So first, how did I get here? So I did start at Bethel in 2004 and graduated in 2008. I studied psychology primarily under Dr. Paul Lewis as a mentor, also with Dwight, and Spanish under Dr. Martha Paterka. Studying at Bethel was a really wonderful opportunity for me. One of the highlights for my career here was the opportunity to study abroad in Barcelona as part of my Spanish degree. Studying abroad there not only gave me an opportunity to pursue my own honors thesis in psychology while I was studying in Barcelona, but also it enhanced my Spanish-speaking skills well enough that I had the opportunity to attend the National Cancer Institute summer internship program. At the time, my older sister was working in the pediatric oncology branch there, studying neuroscience, and she was working under Dr. Laurie Weiner. I told her that I had been studying in Spain, and Laurie was interested in my shared interest in palliative care and actually enabled me to come and spend 2 summers at the NIH. So when I was there, this had a profound impact on me, as Dwight mentioned. We were there primarily to help patients who were coming from all over the world for therapeutic trials. Many of the patients spoke Spanish, their siblings and family members spoke Spanish, and they needed tremendous support as they were facing end-stage disease. These experiences prepared me for a research assistantship that I completed at the VISN 17 Center of Excellence in Waco, Texas, which actually was an opportunity that came my way in part because Dwight Crable connected me with an alumni who was at Texas A&M and told me about this opportunity, introduced me to some people, and they were fortunate. I was fortunate they took a risk on me. They let me come and join them. So when I was there in Texas, I studied under Susie Gulliver, primarily assessing risk and resilience factors for returning war veterans as well as fire service to look at what are the factors that enable some people to develop psychopathology versus maintain resilience in the face of tremendous stress. That assistantship prepared me for an application to a clinical psychology degree. So I entered the PhD program at the University of New Mexico in 2010. I started in a positive psychology lab, so I was studying what it is that enables people to flourish. I then joined a clinical health psychology lab under Dr. Kevin Vowles, where I was studying chronic pain and adjustment to illness. In the latter part of my time there, I had the opportunity to join a research lab in cancer prevention and control, where I was able to study things like breast cancer genetic testing and understanding of genetic risk in breast cancer. And I also had clinical and research opportunity to study under Dr. Marty Edelman, who was a thoracic medical oncologist, which is part of where my interest in lung cancer started. As part of a clinical psychology degree, you have to complete 1 year of dedicated clinical work at an outside institution. So I completed mine at the University of North Carolina in Chapel Hill, where I studied behavioral medicine. So I was primarily doing clinical work with people facing end-stage heart failure or other solid organ failure, as well as cancer patients. Following that experience, I applied for a National Cancer Institute funded postdoctoral fellowship at Wake Forest, where I studied cancer survivorship and cancer care delivery, or how we are reaching cancer patients. During this time, I continued to focus on lung cancer, working with lung cancer physicians. all of these experiences really shaped my thinking about interventions for people facing disease. So as a clinical psychologist, I am at my core focused on interventions. But whereas when I started, I was really focused primarily on patient interventions, one-on-one interventions that are more traditional psychotherapy, every different healthcare setting that I was in started to shift my thinking from how do we just intervene through traditional models to how do we intervene to help family members, to help providers, and really change our care system so that we can optimize quality of life outcomes for people facing serious illness. That led me to my current position as an assistant professor in behavioral medicine or behavioral science at the University of Kentucky. My research program broadly is focused on interventions, primarily for people with advanced stage cancer. I have a strong emphasis in lung cancer, but I'm also expanding it to colorectal, head and neck, gynecologic cancer, and caregivers or family and friends of people facing cancer. I'm interested broadly in what we refer to as supportive care interventions, or interventions that aren't targeting therapeutic drugs in cancer, but are positioning people to improve their quality of life. So I'm primarily interested in improving quality of life, how people understand what their prognosis is and their illness, trying to increase palliative care and supportive care utilization during treatment, and then how we can mitigate financial hardship that often accompanies serious illness. And I have become increasingly focused on thinking about how we do this in the community. So not just the academic medical center where resources are in abundance, but how do we reach the people that are doing a lot with very limited resources? And that has led to my thinking about how care is delivered and how we can develop what we call multi-level interventions to target patient, provider, and system-level factors. But throughout all of my journey in research, the core questions that have driven me really come down to these two questions. How do we think about what it is that enables people to live well in tremendous adversity? And how do we bolster these resilient behaviors that people have? Which has led me to the study of hope in advanced stage cancer. So first, just a little bit about why lung cancer in particular. So if you're in one of Dwight's classes, you know that lung cancer is the leading cause of cancer mortality in the US and globally. So just within the US, it accounts for over 150,000 deaths a year. It also is the second most diagnosed cancer in the US, accounting for over 230,000 new cases of cancer a year. And the vast majority of these are diagnosed in advanced stages of disease where prognosis is pretty poor. It's also a highly stigmatizing disease. So this is an anti-stigma campaign from the Lung Cancer Alliance. Lung cancer, because of its smoking etiology, is highly stigmatizing for many patients. So oftentimes, patients who have lung cancer will not disclose their diagnosis to other people because they are afraid that they will be met with the question, did you smoke? Which often is an implication for them that they somehow deserved the disease that they're facing. Lung cancer, compared to many other cancers, does not receive the sort of social campaigns and awareness that other cancers do. And perhaps in part because of the stigma of lung cancer patients tend to present with multiple unmet supportive care needs, higher rates of distress, including thoughts of suicidal ideation, as well as a reluctance to see other providers, including mental health providers. The other reason why I think it's important to start with lung cancer is that it is a disease that reflects tremendous disparities that overlap with rural disparities. So lung cancer has a higher incidence and mortality among people who live in rural areas, many of whom are living at lower income levels, have less education, and have less access to high quality cancer care as well as mental health care. My interest in hope actually started at Bethel College, and Paul can probably help me reconstruct this a little better, but I remember in our psychology textbook at the time, there was one page in there about positive psychology. And then Rick Snyder, who was at the University of Kansas, I don't know if he came and gave a talk. I have this worksheet still from him on hope. And I just found this construct very fascinating. So Rick Snyder defined hope as a positive motivational state that arises from having goals, perceiving that you have multiple ways to pursue those goals, and that you have the will to use those routes to your goals. So these are some of the items that assess the construct of hope. So these are the agency component, or the willpower of hope, if you will. So things like I'm energetically pursuing my goals, I meet the goals I've set for myself, my past has prepared me well for my current situation and my future. The pathways component of hope, or the how of hope, is really the sense that you know what you need to do to reach your goals. A lot of people ask me, what is the main difference then between hope and optimism? There are a number of positive psychology constructs, including self-efficacy, that are really kindred with hope, but there are some important distinctions. So depending on how you're defining optimism, you can think of optimism as an attributional style or a tendency where you have a positive view of the world, or you have this strong expected outcome where you think things are going to end up being positive, you will be able to accomplish something. Whereas hope can be conceptualized as both a tendency or a trait and a state. So people's level of hope can fluctuate. And hope really places the emphasis on the process of goal pursuit and not necessarily, not necessarily the outcome of accomplishing that goal. So as Dwight mentioned, I studied hope in firefighters. So when I was at the University of New Mexico, one of the first studies I did was a daily assessment study of hope and mindfulness and stress and coping in firefighters. And I found that both individual differences in hope as well as within-person differences in hope predicted higher positive affect, and it seemed to be an adaptive strategy for coping. This was coupled with my clinical experience. So in graduate school, I was working primarily with people facing heart failure who had had heart attacks, as well as cancer patients. And I really found that goals seemed to be a way that people used to maintain a sense of normalcy. The goals provided structure to people's daily lives, and it allowed them to think of what it was that they could do still. Patients came up with all sorts of goals, and these were inherently meaningful to them. They could be everything from just organizing their house, to becoming more involved with their church, to doing a fishing trip or some event with their family member that was important. But in the context of serious illness, what inevitably happened for patients is they would be met with some symptom that got in the way of their goal, or they would face tremendous physical decline where a goal that was important to them was no longer feasible. And the patients that seemed to do well in response to this were those that could come up with a new goal that still somehow tapped into the core value or what was important about that goal, but had a form of the goal that they could actually pursue that was feasible. And this is where the construct of hope really fits nicely with what I was observing clinically. I read a cross-sectional study, so a one-time survey study of patients who were on treatment for lung cancer, where they showed that patients who had higher levels of this particular construct of hope had fewer lung cancer symptoms and less distress. So I was very interested in looking at the construct of hope longitudinally, which led to my doctoral dissertation. So I, again, did a daily assessment study of hope, stigma, and functioning in lung cancer patients on treatment. I'll share a little bit about that now. So one of the limitations of cross-sectional research is that you can't necessarily know that something caused something else. So doing a longitudinal study where you're looking at these variables over time gives you a stronger signal of potential causal relationship. So I wanted to look at, first of all, do people who have higher hope report better functioning during their lung cancer treatment after you adjust for things like physical function, disease symptoms, and disease treatment? Then I also wanted to look at what is the effect of daily fluctuations in hope for these patients on their functioning. So is it the case that when a person experiences higher hope than usual, that they report better function? For this study, I recruited patients who were on active treatment for lung cancer. They had to be physically well enough to be out of bed for at least half of the day. I met them in the chemotherapy infusion suite at the University of New Mexico, administered a baseline survey to them, and then for 21 consecutive days, they answered a brief set of questions about their hope, their functioning lung cancer symptoms, and their experiences of stigma. The main measures that I was interested in for reporting outcomes from this study was one of daily social and role function. So an example item from this is, did your physical condition or medical treatment interfere with your family life today? And then I chose a subset of hope items that I thought could vary more day to day and administered those each day as well. 50 patients agreed to participate in this study. We had about 60% of our sample that was female. Average age was 69. 41% had a high school degree or less, and the majority of them had advanced stage disease. In terms of the daily surveys that they completed, 86% of our sample completed at least 20 daily surveys. So we had excellent adherence to our proposed protocol for this study. And we did find that people who had higher levels of hope, so between person differences, predicted better function, adjusting for physical symptoms and physical status, so how well somebody was doing in terms of being able to be out of bed. But we also found that on days that patients reported higher hope, they also reported higher function. And importantly, there seemed to be some carryover effect. So your level of hope today had some predictive power of your level of hope tomorrow in this study. So based on this, I concluded that there is a signal here for hope predicting function, that this does seem to be some construct that could be beneficial to patients. But I didn't know if patients would be interested in an intervention. Again, knowing that lung cancer patients tend to be a very difficult population to reach through traditional psychotherapy, I wanted to think very carefully about how we could reach this population. One of the studies I completed on my postdoctoral fellowship was actually an intervention development study to develop a hope intervention for these patients. To do this, I surveyed 60 lung cancer patients who were receiving treatment for immunotherapy, which is a new treatment, relatively new treatment for lung cancer. I asked them about what types of goals they were pursuing. So I administered a measure where they could list what we referred to as personal projects or goals. I then asked questions about how meaningful are these projects to you? How important are they? How much is your cancer interfering with these goals? And how much progress are you making on them? How satisfied are you with that? We then asked questions about their interest in a hope intervention and their delivery preferences. So things like, how interested would you be in talking with somebody about ways to help you meet these goals? We found that patients had a number of goals that we could actually support. So the most common goal category for patients were goals related to their work or leisure activities. So an example of this is a hobby. So we had patients say they wanted to paint more, or they wanted to read more. A lot of patients also had goals related to their social life or their family. So many patients reported just wanting to spend more time with family members. Patients also reported what we considered sort of values or identity goals. These really reflected the stance that they wanted to take in the face of cancer. So maintaining a grateful heart was something that patients often told us. We did see some physical goals reported as well as disease management. So a few patients wanted to quit smoking. And the types of goals that you might be afraid that patients might say, so goals like, my goal is to be cured of my cancer, were very infrequent. Most patients were not focused on those goals. They were focused on goals related to everyday living. We also found that patients were highly interested in a goal-focused intervention. Patients said it was important to pursue these goals, that it would be helpful to talk about goals with someone else, that their oncology team should actually monitor these types of goals and talk with them about it. And they were interested in learning ways to pursue these goals during their treatment. In terms of preferences, not too surprisingly, more people were interested in meeting with a nurse compared to a mental health provider. So knowing people were interested, we set out to design an intervention for this group. So I first met with medical providers. I met with medical oncology providers, palliative care, supportive care, nursing, and I just talked with them about this intervention idea and how we could reduce patient barriers for accessing it. They recommended that we deliver the intervention while patients were receiving chemotherapy, so actually in the infusion suite, that we keep it brief, and that we document these goals in the electronic health record for providers to see. I then collaborated with two clinical psychologists, one of whom had studied under Rick Snyder at the University of Kansas and focuses on hope, and another one who had expertise in psycho-oncology and the measure of cancer-related goal interference that I had included in this study. So we worked together to put together a treatment manual. We scripted a patient workbook. We then went back to the hospital staff to show them this intervention to see if it was something that they could actually implement in their clinic. And then we met with patients. We went back to 12 of the survey patients, showed them the materials, had them give us feedback on potential changes to make. In the end, we ended up with a 5-session intervention. The majority of it is delivered during 2 in-person sessions while people are receiving their treatment for lung cancer. And we supplement that with 3 brief phone calls. So it's a very brief intervention. Most psychotherapy interventions for cancer patients consist of hour-long sessions, at least 6 to 8. So it's a pretty reduced protocol. It's very focused. The healthcare provider who delivers this intervention documents patients' goals and potential goal obstacles in the electronic health record. And this just gives you a sense of the content of the intervention at each session. So we start by talking with people, just getting to know them, like what's important to you? What values do you hold? What sort of goals can you set that will help you feel like you are living those values during this difficult time? And how can we help you pursue those goals? We work with them to draft a letter to their provider where they indicate these are the types of goals I'm pursuing, and here's where treatment or disease is getting in the way. And then we work with them on how to overcome obstacles to their goals, as well as identifying personal strengths that they hold that can help them when times get difficult. In the 4th session, we have them identify a touchstone. So it's a physical reminder, a tangible reminder of why they're pursuing these goals. So people come up with things like photos or jewelry from a family member, just something that kind of anchors them on difficult days. And then we talk about how to go forward. This is supplemented with a toolkit, which is basically a resource guide for patients that includes handouts on how to deal with difficult lung cancer symptoms, how to address lung cancer stigma. So what do you do if somebody asks you if you smoked, or people seem to not know what to say to you when you tell them that you have cancer? And key contact information for our cancer center for resources. This work led to an RO3 submission to the National Cancer Institute. So an RO3 is a 2-year, $50,000 a year grant. It's a really small grant as far as the National Institutes of Health is concerned. And they're really geared towards pilot studies. So in this study, what we wanted to do was actually pilot this intervention for feasibility and acceptability. Our first aim in this grant was to refine the intervention content by basically running through it with 6 patients and getting their feedback on what it was like to go through the intervention. We then wanted to look at feasibility and acceptability, as well as gather preliminary data on potential outcomes that we would include in an efficacy trial. Our hypothesized criteria for feasibility was that we would be able to enroll at least 60% of the patients that we approached. So people being interested in this study is a key marker for feasibility going forward, as well as retaining 70% for follow-up questionnaires. So having patients who not only start the study, but are able to complete the end measures that we include. And then looking at adherence, so patients completing at least 3 of 5 sessions, and acceptability ratings of 7 out of 10 on a scale. Again, these were participants who were undergoing treatment for advanced stage lung cancer. They were pretty early into their treatments. They were 3 to 12 weeks into cancer treatment. They, again, had to be out of bed for at least 50% of the time, so able to move around. We met them, we gave them a baseline survey to assess their quality of life, their hope, symptoms, those sorts of concerns. We then gave them the intervention, which took about 7 weeks overall for patients. And then about 8 weeks after they had completed the baseline, they completed a survey again of those measures that we included. The key measures for the survey that we were interested in were primarily hope and a measure of cancer-related goal interference. So our thought is that this intervention, if it is something that would improve depression or anxiety, that it would do that by increasing patients' hope or reducing the amount of goal interference they experienced from their lung cancer. The outcome measures that we're hoping to see improve from this intervention are those that indicate psychological distress. So we have a measure of depression, anxiety, as well as demoralization. Demoralization is a pretty interesting concept. It's very relevant for this population. It's distinct from depression. And it's really characterized by this intense sense of hopelessness, helplessness, and a lost role or meaning in life. So you can have high levels of demoralization without depression, and you can also have depression with or without demoralization. And then we also included a measure of social and role function. So how satisfied are people with their ability to perform their daily activities, their daily routines, their interactions with other people. After AIM-1, the pilot testing with 6 patients, we made some changes to the intervention. So we actually ended up reducing our emphasis on the nurse documenting patients' goals in the electronic health record, which is something I really didn't want to do, but the reason we did it, which you might be able to guess, is that our oncologists weren't looking at these notes. So we had patients who were assuming that their lung cancer doctor had seen the note in their health record of what their goals were. And we were concerned that we were actually sort of hampering patients from taking control of talking about these important things with their doctor because of that. So instead, we added to the toolkit, we added a tip sheet for how to talk with your doctor about what your goals are and a structure that they could use to bring that into clinic. We also included more discussion of lung cancer stigma in the first intervention session because we did find that patients were experiencing clinically high levels of lung cancer stigma. In terms of our AIM-2, the pilot trial for feasibility, we approached 98 patients who met our eligibility criteria. Of those 98, 53 agreed to participate in this study. So the main reason that people cited for why they would not participate was just that they had too much going on. So many people were very overwhelmed. They were early into treatments. In Kentucky, we have people who come from several hours away to receive their cancer treatment. And honestly, just figuring out parking at our cancer center is a lot. By the time they get into treatment, they're already coming in pretty stressed. So we had an enrollment rate of 54%, which fell short of our pre-specified 60% target. But we actually feel pretty good about this. This study occurred primarily during the height of COVID, where patients couldn't even bring their loved ones into cancer treatment with them. They had to go by themselves. There was a lot that they were worried about, and participating in research that may or may not benefit them was not high on their list, nor should it have been, honestly. This enrollment rate is actually pretty comparable to what you see in the broader literature for supportive care trials in lung cancer. So I think it's a pretty good estimate of what we might see in a future trial. Of these 53 people, 52 completed the baseline assessment and were eligible to start the intervention. 48 of those actually did start the intervention. So we had a couple who became ineligible because they were not actually going to receive treatment for lung cancer, so they wouldn't be coming in. And then we had a couple that withdrew from the study. 40 of those 48 completed a post survey after the intervention. So one of the things you do in this sort of research is People might drop out of the interventions. They might say, I don't want to do this intervention anymore, but you still try to collect their follow-up data so that you can look at the people that didn't receive the intervention, what their outcomes were compared to those who stayed in the intervention. So we had a few people that dropped out that still said, yes, I'll complete your post survey. So overall, we achieved a 77% adherence. So 77% of the people that started this study completed at least 3 of the intervention sessions. On average, people completed 4. So we had good attendance in the intervention. And 77% of our people that enrolled completed the post survey. So we met most of our markers for feasibility. The sample, just to give you a sense of who participated, we enrolled 52 people, 60% of them were female. Average age was 61, which is actually a little young for a lung cancer sample. Average age for diagnosis of lung cancer is 65, 66. About half of our sample had a high school degree or less, and the vast majority of them were rural. So Kentucky is predominantly a rural state, similar to Kansas in a lot of ways, but it's a little different type of rural too. Patients had been on treatment an average of 6 weeks. So they were 6 weeks into starting their cancer treatment. And pretty much everybody had distant metastases where their lung cancer had spread to other parts of their body. In terms of acceptability, we looked at acceptability in a number of different ways. So we were interested in how convenient people felt like this was, how helpful it was, how relevant it was for them, if it was something that they felt was worth doing, if they would use what they learned in the future, and if they would recommend this to somebody else. So we had a 10-point scale, and we were hoping to receive an average rating of 7 or higher on this 10-point scale, and we did. People on average rated this an 8 or higher. And this includes the people who dropped out of the study. So you would assume that those who dropped out of the intervention didn't like something about it and would rate it lower for acceptability. So just including them with our other group, we still had high acceptability ratings. In terms of potentially changing the things that we're hoping to change through this intervention, these are just preliminary data, but they're interesting to look at. So what these plots are showing is people's average level of hope and goal interference before they started the intervention. So that's the pre-column there. And then their average scores after they completed the intervention. That's the post. So what we would hope to see for the hope measure is that there would be an increase in hope from this intervention. And that is what we found. So on average, people increased their hope by about 4 points by participating in this study, which had a moderate effect size. So the D there is referring to the effect size, which indicates that we did move hope in a clinically meaningful way. For goal interference, we were hoping to see the opposite, where we would reduce goal interference, and that is what we found. So we had, on average, about a 4-point decrease in goal interference, again, with a moderate approaching a large effect size. So this was a good sign for us that we were moving in the direction that we wanted. In terms of mental health outcomes, again, these are all preliminary, but what we hoped to see is decreases in depression symptoms, anxiety symptoms, and demoralization. So on the left, you can see the pre-scores. So before they started the intervention, those are higher than their post scores. And we had small effects on these. So small effects on depression, anxiety, and demoralization. But I have an asterisk there on the depression one because one of the things that you can do with this measure is look at people who had what we would consider clinically significant depression symptoms. So we didn't have a diagnostic interview to indicate who has depression, who would meet a diagnosis for depression, but you can look to see who would likely meet a diagnosis based on their symptom severity. And if you just look at those patients who had clinically elevated depression symptoms, we actually had a large, moderate to large effect on depression. So that's promising. And then for increasing social and role function, we did see, again, small increases in the direction that we would expect. So all of this suggests that the main thing that we wanted to learn from this is that pathways would be a feasible intervention. We have some preliminary data suggesting that it might move outcomes in the direction that we would hope, but we really have no idea if it works. So when you do a single arm study like this, where you're not comparing pathways to some other intervention, you can't attribute these changes to the intervention itself. It's possible that people improved for some other reason. Maybe they got good news about their cancer, or maybe they increased their social support. It could have had nothing to do with the intervention. So we need to test it in a future trial. And that's what we're planning to do. So I'm submitting an R01, which is a 5-year grant to the National Cancer Institute in November, where we're proposing to randomize 210 people with advanced stage lung cancer to either the pathways intervention or what we're calling enhanced usual care, which will basically consist of them receiving the toolkit that we've developed, but not meeting with an interventionist to talk about their goals. A couple of the aims from this study, the primary aim is to actually test efficacy. So to see, do people who receive the pathways intervention show greater improvements in their depression symptoms, their quality of life scores, compared to those who receive enhanced usual care? And we also want to test mediators, or the potential mechanisms of why this intervention works, and look at moderators. So who are the people that seem to benefit the most from this intervention? Who benefits least? So for example, is it the case that people who are older find this intervention more helpful or less helpful? Is it the case that people who have more severe disease symptoms benefit less or more from this intervention? So I'm going to close by just offering some reflections on the degree I pursued, and then share a little bit about my experience at Bethel, if I can. My degree in clinical psychology has really afforded me tremendous opportunity. It's a very diverse degree. You can do a lot with it. From my clinical work, starting doing psychotherapy with patients, that then led me to think about hope interventions and actually train other health providers in delivering hope-enhancing interventions. As part of my degree, I also learned a lot about how you measure psychological constructs, which has led to some really unique opportunities. So I'm part of a national network for clinical oncology trials where they're testing new cancer treatment drugs. And oftentimes they want to include quality of life measures in these trials to look at patient-reported effects of the drugs. So I get to consult with people on what sort of measures they want to include. My training in clinical trial designs has allowed me to collaborate with other people on their own intervention designs that they want to test. So I get to feel like I'm having an impact in other people's studies as well. And I get to mentor and teach. It looks different than what I thought it would. I'm not getting to work with psychology undergraduates as much as I thought I would initially, but I am working in the medical school. So I get to mentor first-year medical students on how do you talk with a patient, how do you take a patient interview, working with medical students and other professionals on pursuing research in a college of medicine, as well as working with the PhD psychology students on their mentoring team. It's allowed me to collaborate with people with diverse backgrounds. So I get to work with healthcare professionals, with epidemiologists, with people that look at big data and health informatics, with communication scientists. And it's led to some really interesting research questions that I could never just pursue independently, whether it's how do we think about new side effects of cancer drugs, or how can we develop financial navigation interventions for people undergoing cancer treatment, to how do we reduce barriers to life-saving cancer treatments that are available in academic medical centers, but not as available in the community. And I just want to end by reflecting a little bit about the gratitude that I feel for studying psychology at Bethel. So the psychology program at Bethel is really remarkable. The classes that I took here, I just listed a few. Sorry, I don't know why I'm getting so emotional. Okay, the classes I took here, I'm just listing a few of some of my favorite courses. Personality would be another one, Paul. I still remember that textbook, Pieces of the Personality Puzzle. Like, I loved personality, and Funder's book. But your approach to teaching psychology felt like such a personal one, where you really reflected on the students that you had in your class, our careers that we were aspiring towards, and you really enriched every single class, whether it was in social cognition, taking us up to celebrate Holy in Kansas City, which I think you did probably every year for your students, which was something I had never been exposed to. Or for you, Dwight, little things that I still carry with me to this day, and I share with other students on how you talk about data and how you present them, which I probably didn't adhere to very well from this guideline, but I do think about it. So the courses here were tremendous. And a big part of that for me was the lab work that we did. So I have many memories of setting my alarm and not wanting to come to the 8 a.m. lab that we had with Paul, and getting there, and there'd be coffee on, and we would call our classmates who hadn't quite made their alarm and get them in for lab, and we would just have this wonderful dialogue. And it's really in lab that I feel like I learned the scientific method. I don't know how long you had to work with me on getting APA style right, but you worked with me a lot on that, and I'm grateful for that. But it also positioned me to think about how I formulate research questions and how you study something. The opportunity to do an honors thesis was also something that I didn't fully appreciate until I went to graduate school and saw how well prepared I was because of that procedure, because of that opportunity. So many people in graduate school had never formulated their own research, had never collected data of their own, and they had to do their master's, and it was their first time doing it. And I had this wonderful opportunity to do it in undergraduate. And the opportunity to think about your own question in particular, I think, was very unique. And you both allowed me to do that and to fold it into my Spanish major. So I studied culture shock when I was in Spain. I got to do this little experiment on emotional disclosure writing for students who were studying. And that was just a very unique opportunity that you afforded me. And I think at the core of just the community of Bethel and your approach to learning here and scholarship, the emphasis on critical writing just can't be appreciated enough. We had a critical writing course our first year, and that I think also helped us really just enhance critical thinking, which is essential for anything that you're going to do. And a big part of this also was convocation. The opportunity to come together as a community twice a week with people who were studying very different things than I was, and talk about a shared issue and get a diversity of perspectives was just really wonderful. I miss convocation, and I have tried to find something similar in an academic medical center, whether it's grand rounds or whatever, and it's just not there. There's something very unique about convocation. And finally, your teaching philosophy, Paul. I still have copies of your syllabi for different classes. And I think that every year you probably wrote a new introduction for the course that you were going to teach, where you offered your reflections on what you hoped we would learn together. And I think throughout all of your courses, you really emphasized scholarship and assumed that learning was something that happens when you have a dialogue between minds. And you entered that with us so beautifully in all of your courses. And it's something that I have tried to emulate when I teach, and I just will always carry that with me. So I'm going to end there with some additional acknowledgements from people at different institutions. And then these are just some photos of my family. I have a 19-month-old. I met my husband when I was studying at the University of New Mexico. He's from Michigan, so these are some Michigan pictures, as well as a picture of the farm that I grew up on and our dogs who were with us throughout our long graduate school experience. And I have my email address up here for those of you who are students who want to talk about different PhD program options. I found my way because of people who helped me, who had conversations about what my options could be. And there are a lot of things that I know now about different career opportunities that I didn't when I was considering it. So I would love to be a resource for you if it's ever something that you want to reach out for, or if you're in Kentucky, I would love to meet you for coffee. So I'm going to end there, and thank you again for attending early in the morning and for inviting me. Yeah. Yeah, I'm happy to take questions. Yeah.
Thank you so much for speaking today. One question I would ask, a lot of the world religions deal with a lot of similar themes, hope, dealing with diversity. So in clinical psychology, is there any overlap with world religions or that within conventions, or are they really just separate spheres?
Yeah. So there is a researcher that you should look into. Her name is Crystal Park. She's done a lot of research on meaning making in illness, and she actually recently developed measures, I don't know if she's published them yet, of meaning making within the Christian tradition. So she is starting to study ways that we conceptualize meaning that are slightly different for people who do have different religious beliefs. I think she started with Christianity, but she's planning to extend it to others. So psychology in general has been pretty secular, but I think there is growing recognition where we need to develop measures that are more aligned with people's experiences and their worldviews. It's a great question. Yeah.
I think this is great. I'm a pharmacist. I work in a medical system, and we do a lot of see a lot of overlap between the two areas. And I was just curious, one of the things we really have been working on is trying to have patients create functional goals beyond just, I want my pain to go away, so you don't have to just focus on pain. And I see that in what you're working on there. I'm just curious, do you think the medical system, particularly oncologists, are focused on that at all? Or is there, is there a lot of work to get to that?
Yeah, so the question is thinking about a functional emphasis in chronic pain management, which I'm so happy to hear that that's happening. There's a large body of evidence that shows that one of the best strategies for managing chronic pain is to help people think about not pain reduction, but increasing function. So what are you willing to experience pain for in the service of, right? And I think there are some oncologists who this really resonates with. And honestly, I think most of them, if you talk with them about it, it's such a patient-centered concept that they do get it. As long as it's, some people do want to focus on, I just want to get through my cancer treatment. And an intervention like this can help those patients too, because you can say, well, what is it that you feel like you need to do that? And let's also diversify your goals. So it's not just getting through treatment, but what else in your life matters? Like, why do you want to get through treatment in the first place? What is it that in your daily life you want to be well enough to do? And I think oncologists will make the time for it eventually, but I think we first have to show efficacy. There's actually, in one of these big clinical trial groups, they're studying physician level hope. So the same construct, but does a physician's level of hope for their patient have an impact on outcomes, which is just fascinating. So I think oftentimes if a psychological construct gets investigated by somebody with a medical degree, it becomes real. So I'm hoping that that will happen more with hope as well. Yeah.
A lot of work being done with psychedelics research. I mean, psychedelics within the stage, cancer and other terminal diseases. You have any involvement in that and see any overlap? Because part of that is sort of, I think, coming out of those things, some people feel hope and do better.
Yeah. So the question is about psychedelics and their role in end-stage cancer and potential opportunity there to help increase patients' hope and cognitive flexibility in the face of that. And I'm not personally involved with that research, but it makes a lot of sense to me. So there are some people that are sort of rigid, are kind of stuck. And I think psychedelics or some other drug could potentially be helpful in just giving them wiggle room enough that you can start to help them think in this other way. I do see a role for that. Yeah.
I've got a couple of questions. One would be,
And is stigma something that can become internalized where people have a hard time even forgiving themselves for?
Yes. Yes.
Okay.
I can say more about it. I just wanted to let you finish your question.
The other part of the question has to do with, the relationship between smoking currently. The overall population level is low, very low in smoking, but among people living with mental illness, smoking is still very high. Yes. And so is that a confounding factor when you're doing this, that more people present with mental illness and then end up with cancer? Yes,
that's an interesting question. So the first part of the question was, do people who experience lung cancer stigma internalize it? And there is the measure that we use to assess lung cancer stigma does have a component that is specifically about internalized stigma. So people do report, like, I blame myself for this illness, or I feel tremendous shame about myself because of this illness. And that predicts people not attending their cancer treatments. So it's actually very problematic. And the second question is about the potential confound for mental illness and lung cancer patients, because a higher proportion of them smoke, and people that have mental illness early on often are predisposed to smoking as well. I haven't thought about it as much as a confound. I always assess smoking status in these studies, and most of these patients have a history of smoking, although many lung cancer patients do not. There are a lot of lung cancer patients who do not have a history of smoking and still develop the disease, but about 80% of them are caused by smoking. I think it wouldn't necessarily change how I would approach intervening with this population, and that's why I haven't necessarily thought about it as much. But you would, I guess I would conceptualize that as yet one more disparity that lung cancer patients are facing, as that they probably came from exposure to potentially traumatic life events and other things that created mental illness early on that led to their smoking, or at least maintained it. Yeah.
Know any being done hope and the ethics of particular in cancer interventions, not just the cancer, but also the eradication. And thinking about radiation, thinking about some kind of neurosurgery on cancer. So, are the things that are going on in relationship to hope?
Yeah, the question is about hope and the efficacy of cancer treatments, whether it's radiation or systemic therapy like chemotherapy. One of the clinical trial groups is actually studying hope before whole brain radiation and hope after whole brain radiation. The assumption there is that hope really is a cognitive construct. So they're looking to see if people are able to maintain their levels of hope after radiation, which is a different question than what you're asking. But there is a body of research for people that Barb Anderson at Ohio State, for example, has studied psychoneuroimmunology, and they are looking at hope as a potential buffer for people who are getting treatment. So there's one retrospective study where they looked at patients who were on palliative care for advanced cancer, and hope predicted longer survival for them, which, you don't want to say that you should just be positive when you're faced with something as horrible as advanced stage cancer, but the potential mechanisms there might be reduced inflammation. It could be some biological mechanism. It could also be other health behaviors. So people who are more hopeful tend to also set more health behavior goals. Maybe they're better engaged with their treatment. So there are probably biopsychosocial mechanisms at play that being more hopeful could be beneficial for. Yeah, it's interesting. Any other? Yeah, go ahead.
How much does the presentation or
of the intervention, how big a variable is the presentation, because I'm assuming that all your patients may be a little different, come from a different background, and respond differently to different things. But how do you adjust to that, or could that affect your outcome?
That's such a good question. So the question is on really, does the way that we're presenting this to people have an impact on the effect of this intervention? And I think you're onto something. I suspect it would. So part of the difficulty in a trial like this is you have to have a standardized protocol that everybody is following. But as a clinician, you're always sort of tweaking things as you're talking with someone to try to build rapport and make sure what we're talking about resonates. So for example, we had some patients who said, I'm old. I don't set goals, honey. I'm not setting goals. The time for goals is past. And so we had to reframe our language and say, let's forget about the goal stuff. What do you want to call this? Let's just talk about the things you want to get done. And they were able to stay with us because of that. So I do think it has a big effect. And I also think even the presentation of materials, whether it's like a handout or a workbook, some people like that stuff and many people don't because it feels like homework, right? So there's probably a lot of tailoring that should happen to increase the reach of this sort of intervention. Because it's the people that don't tend to go see a psychologist or a therapist that we really want to reach. The people that would use those services anyway are probably going to do okay, but we have to reach the people that aren't necessarily mental health users. So it's a challenge. Yeah. Okay. Anything else? Thank you so much for talking with me about this. It's really exciting to get to share it with you.
I'm sure Laurie would be happy to answer your questions individually.